In this first section of endocrine pharmacology, we will be going over androgens and adrenocortical steroids. In this section, we'll discuss the pharmacology of androgens and adrenocortical steroids. Before we talk about synthetic androgens, we'll talk about testosterone, which is the principal circulating androgen in men. Testosterone is secreted by the Leydig cells of the testes in response to LH secretion by the anterior pituitary gland. Testosterone has many actions. Its first action is to bind to androgen receptors in the target tissues. It also is converted by 5-alpha reductase enzyme in peripheral tissues to DHT, or dihydrotestosterone, which can bind to androgen receptors as well. Testosterone is also converted to estradiol, which is an estrogen naturally occurring in humans, which binds to the estrogen receptor. As you can see here, testosterone, which is a naturally occurring product, is converted back and forth to androstenedione in the human. Aromatization can occur, which converts testosterone into either 17-beta estradiol or estrone. Medications that are aromatase inhibitors are able to block this conversion and decrease the concentration of estrogens. This is especially useful in patients that have breast cancer that have estrogen receptor positivity. Testosterone derivatives have many therapeutic uses, but the major indication is male hypogonadism. This can be either acquired or genetic, for example in Klinefelter syndrome. Certain testosterone esters can be used clinically. These can be transdermal preparations or gels. They can be intramuscular depot injections. Repletion of testosterone in patients that have low testosterone levels can have multiple benefits in the elderly male population, including increased energy. Anabolic steroids such as methyltestosterone, oxandrolone, and stanozolol are meant to increase muscle growth in patients that have muscular problems. They do have legitimate clinical uses, but often are used illicitly in athletes that wish to increase muscle mass and increase their athletic performance. These medications are similar to testosterone in structure. Patients that take anabolic steroids can show many adverse effects from these medications. You should know what these are for the USMLE Step 1, as well as for your practice in the future. These patients can exhibit aggressive behavior, acne, gynecomastia, testicular atrophy, hypertension. Hepatic cancers are sort of the idiopathic or idiosyncratic side effect from anabolic steroids. Glucose intolerance, decreased HDL levels, as well as alopecia and amenorrhea, especially in women. When steroids become 17-alpha methylated, they're able to cause hepatotoxicity. This 17-alpha alkyl substitution creates 17-methyltestosterone, and this 17-methyltestosterone is often a cause of hepatotoxicity. So patients that take these anabolic steroids generally have a higher level of methyltestosterone, and that therefore they're able to cause more hepatotoxicity. This is why patients that are taking anabolic steroids are more likely to develop liver cancer. Androgens and anti-androgens are very important in the treatment of prostate disorders. The prostate gland is strongly affected by DHT. DHT levels can increase prostate cancer growth, and therefore anti-androgen therapy is used for metastatic prostate cancer. The goals of the anti-androgen therapy are to both block the androgen receptor as well as inhibit 5-alpha reductase. Combination therapy with flutamide and leuprolide for patients that have prostate carcinoma will help these patients develop a better outcome, even though they may have advanced prostate cancer. Flutamide is an inhibitor of testosterone at the nuclear receptor, whereas leuprolide is an agonist at GnRH. The way leuprolide works is it causes GnRH to be released in a sustained manner, which blocks the feedback stimulation of increased GnRH in LH that results from flutamide's anti-androgen actions. Cyproterone is actually a partial agonist that works at androgen receptors in the prostate, and it's used to block androgen effects. And it not only works in prostate cancer, but it also can curb precocious puberty in males. It is also a means for causing chemical castration in sexual offenders, and it can be used in polycystic ovary disease as well as prostate carcinoma. Spironolactone is also used in polycystic ovarian disease in women to block androgen's effects. A class of medication called 5-alpha reductase inhibitors that includes finasteride and dutasteride are commonly used for BPH, or benign prostatic hypertrophy. These medications work by decreasing the levels of dihydrotestosterone. They also work for male pattern baldness. This is because hair follicles and the hair follicle growth is inhibited by dihydrotestosterone. Our next category is adrenocortical steroids. The adrenal cortex is responsible for synthesizing corticosteroids, both glucocorticoids and mineralocorticoids, as well as androgens and estrogens. Corticosteroids, when given to the patient by a doctor, can cause numerous and widespread effects throughout the body. They can cause carbohydrate and protein and lipid metabolism changes, as well as hypertension and edema. They can cause immune suppression due to their effects on white blood cells. They can also cause salt and water retention, weakness and atrophy, euphoria and psychosis, and they can also cause adrenal insufficiency when they're given for a long period of time and then stopped suddenly. Glucocorticoids work at the glucocorticoid receptor, which is the nuclear receptor inside the cell. Cortisol, or hydrocortisone, is the major endogenous glucocorticoid, and it's clinically used for many different applications. Clinically used glucocorticoids often are synthetic derivatives of cortisol, and these glucocorticoids are used extensively in the management of inflammatory diseases. These medications are immunosuppressants. Glucocorticoids can also be used as replacement therapy for adrenal insufficiency known as Addison's disease. This occurs during congenital defects such as congenital adrenal hyperplasia, autoimmune adrenal disease, hypothalamic damage or pituitary damage, also shock, trauma, and infection. ICU patients in septic shock usually will be administered glucocorticoids in order to prevent against adrenal insufficiency. Glucocorticoids also can stimulate fetal lung development and production of surfactant. Women who will deliver before 32 weeks gestation are often given a steroid in order to help the fetal lung mature so that it can breathe properly. The clinical derivatives of glucocorticoids include hydrocortisone, prednisolone, and betamethasone. Compared with cortisol, these have better bioavailability, a longer half-life, and less mineralocorticoid activity. The adverse effects of glucocorticoids cause Cushing's syndrome, and this is characterized by altered fat deposition, muscle weakness, skin striae, easy bruising and acne, hyperglycemia due to increased gluconeogenesis, osteoporosis, and electrolyte imbalances. In a patient that you start on long-term glucocorticoids, you should be very wary of these side effects. Furthermore, these side effects can include suppression of skeletal growth in children, decreased wound healing, immune suppression, and various central nervous system effects, including psychosis and euphoria. Glucocorticoids can also suppress ACTH secretion from the anterior pituitary gland and can cause adrenocortical atrophy because of that decreased ACTH secretion. It's very important that when patients are on chronic glucocorticoid therapy, particularly high doses and for a long period of time, they should never be abruptly withdrawn. This is because patients can go into an Addisonian crisis, which is also known as adrenal insufficiency, because their adrenal cortex has not been producing glucocorticoids while they've been on these high doses of extraneous glucocorticoids. You've seen this slide before, but it's meant to show the side effects of glucocorticoids. These would include facial changes, decreased or increased fat deposition, especially in the back and the trunk, easy bruising, and skin atrophy. This concludes our section on androgens and adrenocortical steroids. In our next section, we will go over estrogens and progesterone.